Core Topic 1, the aims of immunisation, national vaccine policy and schedules. The ultimate aim of vaccination is to control a disease successfully. So before designing a vaccine programme, it's really important to establish, is there actually a need for that programme? So does the disease cause a significant public health concern? A good example of this would be COVID-19, which absolutely did. And then we need to think, is there a suitable vaccine available that is both safe and effective? Overall, there could be different aims of vaccination policies. One could be to eradicate the disease, as in the case of the global eradication strategy for polio, and this normally requires mass vaccination. Or it might be a selective vaccine policy to protect those at the highest risk, for example, shingles or flu. Or alternatively, it could be to control outbreaks, so the extension of the measles, mumps and rubella campaign to include older people than children who had missed out on the vaccine previously to control local outbreaks and increase herd immunity. Now, from this infographic, you can see the historical vaccine development and introduction of routine vaccine programs in the UK. It's a useful document to have a look at to just understand where vaccines were introduced along that timeline, from smallpox being introduced in the 1700s all the way up to the human papillomavirus HPV vaccine in 2019. Then we have the routine immunisation schedule. This is updated routinely and it includes key information including age a person receives a vaccine, what disease is vaccinated against, the vaccine given its trade name and the route of administration. It's a really important document to be familiar with and to keep a copy to hand, ideally electronically. Save it into your favourites bar. Try not to keep one printed out because if it goes out of date and you forget to update it, that could be a problem. This is the vaccination of individuals with uncertain or incomplete immunisation status. So this document guides the immunisation of those people who, for whatever reason, have actually deviated from that routine immunisation schedule that we saw on the previous infographic. Now, depending on the person's age and what vaccinations they've had previously, will guide what immunisations they require to bring them back in line with a routine immunisation schedule. Some important points to remember are, unless there is a documented or reliable verbal history, individuals should be assumed to be unimmunised and a full course of immunisations planned. Individuals coming to the UK partway through their immunisation schedule should be transferred onto the UK schedule and immunised as appropriate for their age. Now, if the primary course has been started but not completed, resume the course. There is no need to repeat doses or restart a course. And plan the catch-up immunisation schedule with a minimum number of visits and within the minimum possible timescale. So aim to protect that person in the shortest time possible. In the interactive session, we will try using this document just so people can get a feel of how to use it, because although it looks a bit scary to begin with, it's actually not too difficult to use. UK vaccine policy is published in the Green Book, available on the gov.uk website. Now, Part 1 contains information on principles, practices and procedures, and Part 2 contains chapters on individual diseases, vaccinations and vaccines. Now, it is essential you become familiar with the Green Book and routinely access it. The Green Book is the ultimate resource when it comes to immunisation, and the answer to the majority of immunisation questions can be found within the Green Book. Also, it is important to keep updated with vaccine policy by reading the vaccine updates. Published 4 to 8 weekly by the UK Health Security Agency, the vaccine update can be found on the gov.uk website. This is an important part of remaining updated as an immuniser. So you should absolutely, after this session, sign up to these updates. Additionally, if you want to know more about future plans for vaccination and immunisation, this information comes from the Joint Committee of Vaccination and Immunisations, also known as the JCVI. Now, the JCVI is an independent expert advisory committee, which much more people are now familiar with since COVID, who review all evidence on immunisation and make recommendations to the Department of Health. And you can read the meeting minutes at the gov.uk website. Core Topic 2, the immune system and how vaccines work. Prior to this session, you were advised to watch a series of videos on immunology. If you haven't, we strongly recommend you do so. This is really important, as the more you understand about basic immunology, the better you will be able to understand those key concepts and answer questions that people have. However, I am going to summarise some of the really important points about the immune system and how vaccines work. So immunity can be either innate or adaptive, and innate immunity is the body's defences. These are physical barriers, things like tears, gastric acid, your skin. Then there's adaptive immunity, which can be either passive or active. Now, passive immunity is provided when a person is given antibodies to a disease, rather than them producing it through their own immune system. So this can be done maternally through the placenta to newborn babies, or artificially when we give immunoglobulin to people after exposure to things like rabies and hepatitis. So there's also active immunity, which results when exposure to a disease organism triggers the immune system to produce antibodies. So active immunity can be acquired through natural immunity, so exposure to the disease from the population, or vaccine-induced immunity. Sometimes it's also referred to as acquired immunity. But the basic immune response to vaccination stimulates the active immune response, stimulating the body's antibody response, creating long-lasting immunity, whereas passive immunity is only short-lasting. It's also important to understand herd immunity, because this provides indirect protection of those who are unvaccinated as well as vaccinated individuals. So herd immunity only applies to diseases which are passed from person to person, so wouldn't apply to things like rabies. And certain groups of people, like those who cannot be vaccinated because of immunosuppression, they rely on herd immunity to protect them from a contagious disease, such as measles. So by having a high enough immunity within the population, as you can see from this image, would stop the disease from spreading throughout the community. Now, it's also important to understand the reason for intervals between vaccines, and understanding immunity helps you to do that. So intervals are there to allow your immune system to develop an appropriate primary immune response before the next dose. This allows a true secondary immune response, which is faster and stronger, and with each subsequent booster, immunity will build in this way. So for most vaccines, there is a 1-month interval, but for some, this can be 2 months. But this is why, if you do give a vaccine too early, it is important that you have to re-give the vaccine at the appropriate interval, because that person may have built a substandard and suboptimal immune response to that vaccine. A really common concern and query from parents is that vaccines might overload the immune system, and it's really important that we are able to reassure parents that this is not the case. Actually, within hours of birth, a baby's gastrointestinal respiratory tract are heavily colonised with bacteria, and actually, rather than overwhelming the immune system, vaccines help to stimulate and strengthen it. So immune systems need stimulation to develop well, because actually allergies may result from too little immune stimulation in our cleaner environments. So there is actually no evidence at all that vaccines can overload the immune system. The immune system is designed to deal with a constant stream of foreign antigens on the surface and inside our body. So the only limit to the amount of vaccines that we can have is actually the amount of limbs that we have. So there is actually no upper limit of the amount of vaccines you can have in one go. Core topic 3, vaccine preventable diseases. Now, prior to this session, you should have done training on the e-learning for health platform for every vaccine preventable disease that you as an immuniser intend on immunising against. Now, the reason for this is so that you as an immuniser are able to describe the main signs and symptoms, mode of transmission and period of infection of each different vaccine preventable disease in the UK you will be immunising. You should be able to describe the nature and frequency of acute symptoms and potential long-term complications of those diseases, and know where to access further information about each disease. Depending on your role and current level of qualification will depend on which vaccinations you will be giving. Healthcare support workers are currently only supported in giving the shingles vaccine, the flu vaccine, the live flu vaccine and the pneumonia vaccine in adults. Registered professionals are supported in giving any vaccine as long as they have a knowledge of that vaccine preventable disease. These are all the diseases we vaccinate against on the routine immunisation schedule. However, there are other vaccinations which may be given on a more selective basis based on the person's need or request, so the TB, BCG vaccine or travel vaccinations. Then of course there's the COVID-19 vaccination, which is now also available, and that schedule is constantly changing. And it's important to remember that healthcare support workers are only supported in giving their influenza for adults and live influenza for children, pneumococcal vaccination, shingles vaccination, and the coronavirus vaccination. So these are the only ones healthcare support workers can give off a patient-specific directive. Influenza and COVID-19. Morbidity and mortality attributed to flu and COVID-19 is a major cause of harm to individuals, especially vulnerable people who are at increased risk of death and serious illness. The annual flu immunisation programme and the COVID vaccination programme helps to reduce GP consultations, unplanned hospital admissions and pressure on A&E, and is therefore a critical element of the system-wide approach for delivering robust and resilient health and care services. So why and how do some diseases change and evade our vaccines, and why do we need to change the composition of the flu and COVID vaccine? It is because changes to genomes on the surface antigen result in the virus constantly adapting and evolving. This may be an antigenic drift or an antigenic shift. An antigenic drift is when small changes gradually occur over a period of time. And an antigenic shift is when two or more strains combine, causing a major change, and this results in a completely new subtype. Omicron variant of COVID-19 is a good example of an antigenic shift, whilst a subvariant of Omicron are examples of antigenic drift. These antigenic drifts and shifts are one explanation for changes in prevalence of flu and COVID each year, and also how effective the flu vaccine is each year, which is usually around 30 to 60% effective for adults between 18 and 65 years, but actually even lower in the elderly due to the reduced immune response in the over 65s. Despite this, evidence clearly shows immunisation reduces the incidence of severe disease, including bronchopneumonia, hospital admissions and mortality. Vaccine composition is another factor influencing the amount of flu or COVID we see each year. All flu vaccines are now quadrivalent, which means they contain 4 strains of the influenza virus, 2 A strains and 2 B strains. Each year's flu vaccine composition may differ from the previous year's vaccine composition, as both influenza A and B virus strains may be replaced. The COVID vaccine was initially monovalent, but in autumn 2022 it became bivalent, meaning it contains 2 strains of the COVID virus, and in future it may go on to contain further strains and be trivalent or quadrivalent like the flu. Eligibility for flu and COVID vaccine is constantly changing, and it should be routinely checked using the relevant chapters of the Green Book, so Chapter 19 for influenza and Chapter 14A for COVID-19. There are a number of different flu vaccines available each year, and it is important to be aware of the vaccines you are giving, so you need to know the age indications, but also the ovalbumin, that is the egg content of each of the vaccines. And there is useful infographics that will help you to know this information. But historically, most of the available flu vaccines were prepared from viruses grown in embryonated hen's eggs. Now, in addition to egg-based, other flu vaccines are available that are cell-based or recombinant, meaning people with egg allergies can now be immunised against influenza safely. But adults with severe anaphylaxis to egg, which has previously required intensive care, should be offered an egg-free vaccine, which are highlighted here, or referred to a specialist for assessment with regard to receiving immunisation in hospital if this is not possible. Now, if an egg-based vaccine is to be given to someone with an egg allergy who has not previously received ICU intensive care treatment for anaphylaxis, it must have an ovalbumin content less than 0.12 micrograms per ml, which is the equivalent of 0.06 micrograms per 0.5 mils. So these vaccines are the vaccines that are currently safe to give in people with egg allergy, and these vaccines are not. Core topic 4, the different types of vaccines, their composition and the indications and contraindications. When developing a vaccine, the pathogen cannot be used in its natural state, as this would actually cause active disease and could potentially be dangerous, not just to that individual receiving it, but could risk the disease spreading to others. So to avoid this, modern vaccines use pathogens which have been altered in some way. So live attenuated vaccines contain whole bacteria or viruses which have been weakened, and this is called attenuation. So that they create a protective immune response, but they don't actually cause the disease in healthy people. So live vaccines tend to create strong and long-lasting immune responses. However, they may not be suitable for people who have weakened immune systems or who are pregnant, and this is because the weakened virus or bacteria could in some cases multiply too much and might cause the disease in which they were meant to protect against. Then there's inactivated vaccines. So these contain whole bacteria or viruses which have been killed or have been altered so that they cannot replicate. Now, because inactivated vaccines do not contain any live bacteria or viruses, they cannot cause the disease against which they protect. So even in people with severely weakened immune systems, they are perfectly safe. However, they do not create as strong or long-lasting immunity as live vaccines do. So this is why sometimes adjuvants are actually added to subunit vaccines. Adjuvants are actually substances which help to strengthen and lengthen the immune response to a vaccine. But as a result of this, more likelihood of common sort of localized reactions like a sore arm. Now, in the early days of polysaccharide vaccines, it was found that they did not work well in babies. So actually, researchers discovered that they worked much better if the polysaccharide was attached or conjugated to something else that creates a strong immune response. So there is two types of pneumonia vaccine. One is a polysaccharide vaccine for adults, and the other one is a conjugated vaccine for children, because the polysaccharide vaccine wouldn't trigger a strong enough immune response in children, and this is why it's important you use the correct vaccine. Now, there's also nucleic acid vaccines, and just mentioning these because they do actually work in a different way to other vaccines. They actually provide the genetic instructions of the antigen to the cells in the body, and in turn the cells produce the antigen which stimulates an immune response. So nucleic acid vaccines are quick and they're very easy to develop, and they actually provide quite a significant promise for the development of vaccines in the future. Now, sometimes people may ask for vaccinations to be given separately. This is actually quite a common query, particularly in regards to MMR. But many vaccines are actually combined to make it easy to give several vaccines at once. And combination vaccines do reduce both the number of clinic visits and the number of injections needed. So before combination vaccines are licensed, studies are carried out to ensure that the immune response to any combined antigen is just as good as the response to individual vaccines, and the rates of adverse reactions are the same as they would be if the vaccine were administered separately. So there's currently no licensed vaccines on the routine schedule that are separate for the measles, mumps and rubella. It is only the combination vaccine. But just to reassure people, this is perfectly safe, and lots of studies and research have gone into proving this. So it is important to understand the contraindications and precautions of the vaccines that you give. Now, more information on this can be found in chapter 6 of the Green Book, and it's really worth reading that chapter. But just a few key points to remember. True contraindications to all vaccines are a history of a confirmed anaphylactic reaction to a previous dose of the vaccine or a component of the vaccine. So precautions to all vaccines are if the person has been severely unwell. This is because we don't want any of the illnesses which somebody has to be attributed to the vaccine, or if they're already unwell to then potentially develop a temperature and make them more unwell. Live vaccines are also contraindicated in those people who are immunosuppressed, either for a condition that they have or a treatment that they have received. So live vaccines are also contraindicated in pregnancy. I mean, currently to date, there's no evidence of direct fetal injury caused by administration of a live vaccine. However, there is a theoretical possibility, so it's safest to postpone till after delivery. Now, allergic reactions to a vaccine or a component of the vaccine which is not anaphylaxis are not necessarily a contraindication, but it may be appropriate to seek specialist advice before administering. So treat this as a precaution but not a contraindication. Core topic 5, current issues in immunisation. Immunisation is a constantly changing landscape, and it is your responsibility as an immuniser to remain up to date with all the changes as they happen. There is a number of things you as an immuniser can do which will help you to stay up to date. Now, one of the simplest and the most effective way to stay updated is to sign up to and actually read the vaccine updates as they are published. The Vaccine Update is a regular newsletter describing the latest development in vaccines and vaccination policies and procedures. There is even an index of the topics covered by the Vaccine Update, including revised guidance, policy and programme implementation information, and it has actually been designed so that you can search Vaccine Update content specifically. It is always important to refer to the most recent advice, and the best way to be aware of this as it happens is to be reading these vaccine updates. Also, I've mentioned before the Green Book, so you have to become familiar with and access regularly the Green Book. It's such a valuable resource for all immunisers. You can even sign up to email notifications for when there are changes made to the gov.uk pages on immunisations, so you'll be alerted to those changes. Understand basic immunology. I've mentioned this before, but it will help you understand and answer a lot of questions better. And if you want to be ahead of the game and keep up to date with the latest, look at those JCVI meetings to see what's in the future for immunisation. Updating is a process that is ongoing as changes to vaccination are not happening only once a year. So you cannot just attend an annual update and expect to have kept up to date with what's been going on in immunisations. Saying this, you should also have an annual update on some of the key principles of immunisation which are covered in these sessions. This annual update doesn't have to be an interactive session, but it is considered the best standard for it to be. It can be done through ELF the e-learning for health e-learning and self-directed study, and at the training hub we have actually come up with a resource to help you direct these updates if you are going to do it asynchronously in your own time. It's worth being aware of that when a vaccine news story breaks, it's important for us as immunisers to have a look at reliable websites for their response. So the gov.uk pages and Public Health England and the World Health Organization. Be wary of social media. Social media, do not rely on it. Get your facts from a reliable source. But it is a good idea to be aware of what is being published in social media, as this may be the main source of information for your patients, and so they may find that you get asked questions for information they found in newspapers, online or in social media. So be aware of them and know how to answer questions. In light of the current war in Ukraine, it is important when welcoming Ukrainians to Cornwall that we consider vaccination. Only half of Ukrainians are vaccinated against COVID, so it's important we consider this and offer where appropriate. There was a polio outbreak in the Ukraine in 2021 and a vaccination campaign was due to start, so it's important again to check for polio vaccinations in Ukrainians as well. TB is prevalent in the Ukraine. It has one of the highest rates of multi-drug resistance TB in the world. So important to offer screening for all new arrivals and to offer vaccinations for those who are under 16 who don't have a scar or record of a vaccine. Measles is also prevalent in the Ukraine, and so it is important to ensure that they are fully vaccinated with 2 doses of MMR. Also, there is typhoid prevalent in the Ukraine, so consider this as a diagnosis when treating people from the Ukraine. And then Hep C and HIV. It has the second highest rate of HIV in Europe, so we should offer all under 25s STI screening for this. Core topic 6, communicating with patients, parents and carers about vaccines. There are a variety of things that influence parents or patients in their decision making about vaccinations, from personal experience, attitudes and beliefs, knowledge of the disease, their family and friends, interactions with healthcare professionals, and things that they see or read in the media. And what's really important to remember is, in absence of the disease, the perceived threat of the disease disappears, and the anxieties about vaccine safety increase. Therefore, it is vital that immunisers are able to respond to concerns and correct misconceptions about diseases and vaccines. We need to make time to discuss vaccination and answer questions, be well informed, confident, empathetic and open and honest, recognise factors affecting the individual's decision making and explore any of their specific concerns. Communicate existing knowledge, taking into account what they already know. Provide them with more information in the form of leaflets and recommending other reliable sources. We need to reassure patients. Vaccine safety is taken extremely seriously, and before being introduced, vaccines are rigorously trialled and have to pass strict regulations set by independent bodies. Decisions about vaccines used are made following a detailed risk versus benefit analysis of all available information about the vaccine. Once introduced, vaccines are carefully and continuously monitored, and any suspected reaction is fully investigated by independent experts, often globally. So we need to talk about the benefits of vaccines. Vaccines save lives. They help children learn and grow, and they prevent serious illness and disability. What we need to do is signpost reliable sources of information. The Vaccine Safety Net is a global network of websites established by the World Health Organization, WHO, that provides reliable information on vaccine safety. The Oxford Vaccine Group is one such site in the UK, which provides a wealth of information on vaccines. You can find useful answers on the FAQ page to some of the most common concerns regarding vaccines. The government website is also a useful site for information and to download leaflets. So when communicating risk, it is important to be open and honest about known adverse effects of vaccines. We need to set risk into meaningful contexts and compare risk of the vaccine with risk from everyday activities, compare risk of vaccinating versus not vaccinating, and compare risk from vaccine with risk from the disease. And we should also talk about the lives that have been saved and look at the positive aspects of vaccines. Parents should be provided with all the facts and information they require to make an informed decision, and this includes the risk of the disease, the benefits and risks of vaccinating, the risks of not vaccinating, and in this way they can make the decisions that are in the best interests of them and their child. Core Topic 7, Legal Issues in Immunisation. It is important individuals and parents are informed, and information should include details of the immunisations to be given and the diseases that will be prevented by these immunisations. We should also talk about the benefits and the risks of immunisation versus the risk of the disease. We should also give them any new information that may have been recently changed or in the vaccine updates that we have recently read. Also talk about those possible side effects and how to treat. We should include anaphylaxis in this, but put the risk into context of how it is an incredibly small risk, 1 in a million. We should talk about any follow-up procedures, so they may need to give Calpol, check temperature, site to the injection, and when the next injections would be due. We do actually need to be telling people how data is going to be stored as per Caldecott guidance. And finally, there should be agreement to proceed. So we've given them all the necessary information and now they consent, and that consent is informed. So that sounds like quite a lot. So how much information do people actually need? Well, really, it's as much as the patient parent needs or wants. And this is going to be vary from person to person, and we shouldn't make giving people information a barrier. In fact, if someone's very well informed, maybe they don't need as much as somebody who's quite uninformed and nervous and has a lot of questions. They may just trust you and vaccines and be happy to have, and so you can give them the bare minimum of information. They're not obliged to seek full information, but you must offer it, and we don't want to create those needless barriers, as I mentioned. So just regarding consent, health professionals should ensure they are working with their own competence and scope of practice and refer to guidance issued by their regulatory and professional bodies, or if a healthcare support worker, they are working appropriately under delegation. And consent must always be obtained before every immunisation. So the giving and obtaining of consent should be viewed as a process and not a one-off event, and it must be given voluntarily, freely, and after an understanding has been achieved of what is involved. The person providing consent should be offered, as I mentioned, as much information as they reasonably need to make their decision. Who can consent? So adults over the age of 18 who have capacity can consent. So teenagers aged 16 to 17 are presumed in law to be like adults. However, unlike adults, their refusal of treatment can sometimes be overridden, and this is due to an overriding duty to act in a child's best interest. So this applies to situations where refusal would likely lead to death or some kind of severe permanent injury or irreversible mental or physical harm. Those under 16 who are assessed as Gillick competent can consent, and the Gillick test established children under 16 can consent if certain criteria are met. So if a child does pass this test, they are deemed as Gillick competent, and each individual decision requires assessment of Gillick competence. So a child could be Gillick competent for an immunisation, but not to agree to brain surgery, for example. So if a Gillick competent child consents to treatment, a parent cannot override that consent. But if a child does not pass the Gillick test, then parental consent or court consent is needed in order to proceed. There is no actual lower age limit for Gillick competency. However, it's rarely safe or appropriate for a child under 13 to consent without their parents. And when we're having conversations with children and teenagers, we should be encouraging them to include their parents in their decision making. For babies and young children, mothers automatically have parental responsibility, and fathers have parental responsibility if married to the mother, are on the birth certificate, or have legally acquired it. Then they have parental responsibility. Now, what do we do if parents don't agree about the decision to vaccinate? So although the consent of one person with parental responsibility for a child is usually sufficient, if parents both with parental responsibility disagree, the immunisation should not be carried out until both parents can agree to the immunisation, or there is a specific court approval that the immunisation is in the best interest of the child. And also it's worth noting a mother's parental responsibility and decision does not override a father's. Now, people looking after a child do not have parental responsibility, but they can actually be authorised by a parent to bring a child to their immunisation appointment. There is no requirement for the parent to be present or for this to be in writing. So the vaccine should be given if the professional who is giving the vaccine is satisfied that the person with parental responsibility has made arrangements for the person to be there, information has been given to the parent, and there is no recorded disagreement with immunisation on the medical records. So a good procedure to have in place at your surgeries is that when a person rings to book the appointment, you confirm who's booking the appointment, that it is a parent, and ask who will be bringing the child, and if it is somebody other than the parent, if they are authorising that person to bring that child for immunisation. When a medication needs to be given by a person who is not a prescriber, it can be done so in one of two ways, either by a patient-specific directive or a patient group directive. A patient-specific directive, also known as a PSD, is the traditional written instruction that's signed by a doctor, dentist, or non-medical prescriber. This is for medicines to be supplied or administered to a named patient after the prescriber has assessed the patient on an individual basis. So a PSD must be written and signed by the prescriber, and this can be done either in hand or electronically. A PSD can also be an instruction to administer a medicine to a list of named patients where each patient on that list has been individually assessed by that prescriber. So what should a PSD include? So it should include the name of the patient or some other individual patient identifier. It should also include the age of the patient if they are a child. It should include the name, form and strength of the medicine, the route of administration, so whether that be orally, IM, subcut. It should include the dose, the frequency and the date of the treatment, and also the number of doses, frequency and date treatment ends as applicable. And then it should be signed by the prescriber and there should be a date as well. Now, registered professionals who are on a named list can give immunisations using a patient group directive, or also known as a PGD. These are written instructions for the supply or administration of medicines directly to a patient with an identified clinical condition, and that's without the need for a prescription or a written instruction from a prescriber. So the registered health professional working under the PGD is responsible for assessing that patient fits the criteria that has been set out in the PGD. So PGDs actually only allow specified registered health professionals to work under them. The specified health professional who carries out the assessment under the PGD cannot delegate the supply and administration to another person who is not a specified health professional. Now, although a registered professional, nursing associates currently cannot administer medications off a PGD. An application has gone in to change the law to include them on this list of named professionals, but currently they can only administer vaccines and medicines off a PSD. Also, healthcare support workers cannot work under PGDs, only PSDs. Core Topic 8, the storage and handling of vaccines. Vaccines are expected to remain potent until their expiry date and will do so if stored correctly. Vaccines may lose their effectiveness if they become too hot or too cold at any time. Vaccines do naturally biodegrade over time, and storage outside of the recommended temperature range, including during transport, may speed up that loss of potency, and that loss of potency cannot be reversed. And as you can see from this picture, some vaccines are more sensitive to heat and some vaccines are more sensitive to the cold. Also worth knowing is that vaccines are actually also sensitive to light, so strong light, sunlight, ultraviolet light, fluorescent light, so they should always be stored in their original packaging until the point of use to protect them. Also, when transporting vaccines, you must use a validated cool box and ice packs from a recognised medical supply company. You still need to monitor maximum and minimum temperatures, recording those at regular intervals. Vaccines should be wrapped in bubble wrap or similar insulation material to prevent direct contact with ice packs, using insulating material to fill any spaces within the cool box. Also, remember to only take enough vaccines for your particular session to minimise exposure of the vaccines to room temperatures. So, what is the correct temperature? Well, we should be aiming for between 2 to 8 degrees, but ideally aim for 5 because that gives you a little leeway either side. You should read your minimum and maximum temperatures daily and record them on a log sheet, and you should reset the thermometers after recording. And very importantly, you should react to the temperature if it is outside of that 2 to 8 degrees. So here are a few vaccine storage do's and don'ts. Do check the delivery and put into a dedicated vaccination fridge immediately. Safeguard that electricity supply. It is one of the biggest reasons why there is vaccine errors, because some vaccine incidents because someone has turned the fridge off. Place vaccines in clearly labelled plastic mesh baskets. This allows airflow through the baskets. You should group vaccines by type in a sensible order, so paediatric to adult to adolescents, travel. You should defrost and calibrate your fridges routinely. You should ensure there's backup facilities, so ideally you have multiple fridges, so if there's a problem with one, you have alternate solutions. And you should always position any probe correctly, which is in the centre of the fridge. So things that you shouldn't do is store food or medical specimens in the fridge. You should never overfill your fridge, particularly important to consider this at flu season because it prevents airflow around the vaccines. You shouldn't place your fridge near a heat source or in direct sunlight. You should not remove vaccines from their original boxes because they can be damaged by the sunlight. You should store vaccines only in mesh containers, never in solid plastic trays because it prevents the airflow and this can disrupt cold chain. and you should not allow vaccines to come into contact with the fridge walls or cold air vents because this can cause them to freeze. So a designated person and deputy should have overall responsibility for ordering and receipt and care of vaccines. Care of vaccines includes ensuring cold chain, checking delivery for leakage, damage, discrepancies, rotation of stock, maintaining stock information systems to keep track of orders, checking expiry date and the running total of vaccines. So we should always ensure adequate supply but minimise over-ordering and stockpiling. So we should aim for only ordering 2 weeks to 4 weeks maximum supply of vaccines. So action to be taken if fridge temperature is out of range. So prior to administration, you should take action immediately. If in doubt cold chain has not been maintained, vaccines should be quarantined and not used. Inform all other immunisers on site and management immediately. Complete a risk assessment of all the vaccines. For example, vaccine type, expiry date, length of time of the vaccine outside of the cold chain, and then further advice should be sought from vaccine manufacturers regarding extended viability studies, as some vaccines may still remain potent. And it's also important to contact your local screening and immunisation team and inform them of the incident and seek their advice. So post-administration, if you had unfortunately already given a vaccine and it had been outside of the cold chain, which hopefully won't happen because you've been checking your fridge temperatures, but if that does happen, treat as a serious untoward incident. So suspend all immunisation clinics until resolved. Inform management and the screening and immunisation team of the incident. The patient may need to be recalled and offered the additional vaccine. So where a decision has been taken to continue to use vaccines that have been stored outside of the manufacturer's recommended temperature range, because vaccines that have not been stored between 2 to 8 will not meet 2 to 8 degrees will not meet the terms of their licensing conditions, patients will need to be informed that the vaccine is off-label, but that the administration may continue under a PGD if the necessary risk assessment has deemed the vaccine remains viable. But there is this handy leaflet from Public Health England that explains to patients what off-label vaccine means. So more information on all of this can be found in Chapter 3 of the Green Book, Storage, Distribution and Disposal of Vaccines, the CDC Vaccine Storage and Handling Toolkit, and the Vaccine Incident Guidance, so responding to errors in vaccine storage, handling and administration. Core Topic 9, Correct Administration of Vaccines. Preparation, injection technique, choice of needle length and injection site are all important considerations in vaccine administration. Each of these factors can both affect immunogenicity and risk of local reactions at the injection site. Each vaccine should only be reconstituted and drawn up when required in order to avoid errors and maintain efficacy and stability. When reconstituting freeze-dried vaccines, only use diluent supplied and used within specified time period as per the manufacturer instructions. The diluent should be drawn up using a 21 gauge green needle and then added slowly to the vaccine to avoid frothing. So before administration, you should also check the colour and composition of the vaccine as it is specified in the description in the vaccine's SPC. So check the vaccine to ensure it is the right product and the correct dose for the patient, and check the expiry date. For IM injections, the needle needs to be long enough to ensure the vaccine is injected into a muscle. So a 25mm needle length is preferable and suitable for all ages, and this is the blue needle. A 16mm needle length, so the orange needle, is only recommended for preterm or very small infants. So these would be sort of potentially preterm babies who would probably still be in hospital actually when they had their immunisations, so not ones we would necessarily be seeing in primary care. And a longer length needle, so a 38mm needle, is preferable for adults who have a very large arm, so a fatty area surrounding their deltoid, and it requires a larger needle, but this needs to be assessed on an individual basis. So clean skin does not require cleaning. Visibly dirty skin need only be washed with sort of soapy water. And if you do use alcohol or other disinfecting agents, the skin must be allowed to dry, as those disinfecting agents could inactivate live vaccines. Core topic 9, correct administration of vaccines. In adults and children who are over 12 months, the deltoid muscle of the arm is the preferred site for intramuscular injections. So you can see here where the deltoid muscle is. You need to administer an IM injection in the most central and thickest part of the deltoid muscle. So the best way to find this is by locating the acromion process, which is the bony prominence above the deltoid. You can do this by feeling that bony prominence and placing 2 to 3 finger widths, or about 2 inches below that. And then if you place your thumb in your armpit and your hand goes across your axilla, then you will find that area of where the deltoid muscle is. So it is found approximately 2 to 3 finger widths, or about 2 inches below the acromion process and above the level of the armpit, so in the middle of this area. So you can see it really clearly depicted in this picture. The person has their 2 fingers below the acromion process, and there is a deltoid muscle, and you can see the upside down triangle, and it's in the center of that where the injection site will be. So when 2 or more injections need to be given at the same time, the best practice is to give them in separate sites in different limbs. But if more than 1 injection needs to be given into the same limb, you should give them at least 2.5 centimeters apart, and then document really clearly which injection was given, say higher or lower. And when the number of vaccinations being given necessitates it, the thigh may be used in those who are over 12 months, but only by registered professionals who are trained to do so. So healthcare support workers cannot give injections into the thigh muscle. And immunisation should not be given into the buttock due to the risk of sciatic nerve damage and injecting the fat rather than the muscle, and that causing a localised reaction or a poorer immune response. The preferred injection site for children under 12 months is the vastus lateralis muscle of the thigh. You should divide the upper thigh into 3 equal parts and locate the middle of these 3 sections. The injection should go into the outer top portion of this section. Now, only registered health professionals are able to administer vaccinations into the thigh muscle and other sites than the deltoid. Healthcare support workers should only use the deltoid muscle for administration. IM injections should be given with a needle at a 90-degree angle to the skin, and the skin should be stretched flat and not bunched. As you can see from this image, this is so that the needle will penetrate the subcutaneous tissue and get to the muscle. It is not necessary to aspirate the syringe after the needle is put into the muscle. Not many vaccines are given subcutaneously. Occasionally it may be required for people who have bleeding disorders. However, if it is required, it should be done so by a registered professional who is experienced in giving subcutaneous injections. The TB vaccine is given intradermally, but special training is required for this, and currently it is not done so in general practice but by the specialist TB team. It's also important to consider intervals and spacings between administration of vaccines. So when thinking about inactivated vaccines, doses of inactivated vaccines can be administered at any time before, after, or at the same time as each other. And doses of inactivated vaccines can also be given at any interval before, after, or at the same time as a live vaccine, or vice versa. So there is no rules around intervals and spacings with inactivated vaccines. However, there is some considerations when you are thinking about live vaccines and their administration. So yellow fever and MMR, there needs to be a 4-week minimum interval between these vaccines. So if you're involved in travel health, this is an important consideration. Varicella and zoster vaccines, so your chickenpox and shingles vaccines and the MMR, there needs to be either administered on the same day or a 4-week interval. The TB skin test and the MMR, It can be performed on the same day. However, if the TB skin test has already been done, then the MMR should be delayed until the skin test has been read, unless protection is needed urgently. So those are the three combinations: the yellow fever and MMR, the varicella and zoster and MMR, and the TB skin test and MMR. Other than those combinations, all of the live vaccination combinations can be given at any interval before, after, or at the same time as each other. So if you have a preschooler coming for their live nasal flu vaccine as well in the flu season, they can be administered on the same day, or if they'd had it a week before, they could then still have their MMR or flu. So it's only those three combinations that we need to consider. So when thinking about timing of adverse reactions, inactivated vaccines, as I previously mentioned, reactions usually occur within 48 hours and are more common with inactivated vaccines. But when it comes to live vaccines, reactions occur according to the time taken for that virus to replicate. And the best example of this is the measles, mumps and rubella vaccine. So say you were to give the measles, mumps and rubella vaccine there on day 1. A person may still have a localised reaction in the first sort of 48 hours preceding that vaccination. However, then the reaction to the measles component, so things like malaise, fever and rash, that tends to occur 6 to 11 days following the vaccination. Reactions to the rubella component, so pain, stiffness or swelling of the joints, tend to occur in the 2nd week following the vaccination. And reactions to the mump component, so neck swelling, parotid swelling, tend to occur in the 3rd week following vaccination, although it could actually occur up to 6 weeks following vaccination. So you can see from that, it's really important that we tell patients you could be expecting any of these reactions from 6 days to 3 weeks onwards. Core topic 11, documentation, record keeping and reporting. So when a vaccine is administered, the following information should be accurately recorded at the time of the vaccination being given. Name of the vaccine, the product name, the expiry date, so recording this is evidence that you have actually checked it, the batch number in case of any future problems or recalls, the date the vaccine is given, the site of the injection, including the description of which injection was administered in each site when you're giving multiple injections. And remember, if you're doing 2 in one limb, you need to document which was higher and which was lower, and then your name or signature. It's important to remember registered healthcare professionals have a professional and legal duty of care to their patients, and anything written in your capacity as a healthcare professional could potentially be used in a court of law. So remember this: if you didn't document it, it didn't happen, or at least it's like it didn't happen, because if you were to be called on and your notes were needed to be used, this could be months or years, you will likely have no memory of the event, so you will completely need to rely on your documentation. And immunisation should also be recorded in the Personal Child Health Record or Red Book, and we encourage parents to keep accurate records of these vaccinations. They can be really useful for the parents as a resource if their child ever attends accident emergency or moves addresses. And it's important to report adverse events and suspected adverse drug reactions to vaccines to the Medicines and Healthcare Products Regulatory Agency using the yellow card scheme. It's accessible online or via an app on your phone. It can be done by healthcare professionals or the patient themselves, and any adverse drug reaction for a child needs to be reported, but only serious adverse drug reactions for an adult need to be reported. And if the product is a black triangle product, which means that it is newly licensed and still in the surveillance phase, then also any adverse drug reactions need to be reported. Core topic 12, strategies for the effective organisation of vaccination sessions and optimising immunisation uptake. All immunisers need to make time to discuss concerns about vaccines. We basically need to be knowledgeable and confident and promote vaccination. But there is vaccine hesitancy out there, and it's quite easy to understand looking at this cycle. When we have good levels of herd immunity, there is decreased incidence of a vaccine preventable disease. And with that, we see a reduction in the fear of that vaccine preventable disease. And actually, the perceived risk of vaccines goes up, and the vaccine itself is seen as sort of unimportant. And people worry about vaccine safety. And that leads to a refusal to vaccinate and vaccine hesitancy. And with that decreased vaccine uptake, we'll start to see, whether it be months or years, the re-emergence of vaccine preventable diseases, which leads to an increased need to improve vaccine uptake and introduce new campaigns to encourage and promote vaccination. And then we see the vaccine uptake going up. And this cycle is happening all the time. So how do we convince those people who are hesitant? So we need to use the health coaching style. Ask open-ended questions, like, what do you think about vaccines? What more do you want to know about the vaccine? Listen to them and remain open. Show that you are in favour of vaccines, but also open to the idea that someone may not be. Try not to give all your arguments for vaccines right at the beginning, because you're likely at that point to pick a fight, because they're just going to be thinking of counterpoints. Ask them for permission to give them new information so that they feel in control and are more open to listening to it. And introduce new information by explaining how vaccines were developed, the surveillance that goes into vaccine development and the safety of vaccines and the science behind it. Ask them about potential upsides of having a vaccine. It's more effective if people express it themselves. But take it all very slowly. You're not going to change people's minds in 5 or 10 minutes, and moving too fast can be counterproductive. Sow the seed and offer them time to come back. And avoid trying to convince people or correct people or be the expert. If you're attempting to win an argument, you can get into a battle with someone and it's not really going to help. So what about strategies for the effective organisation of vaccine sessions? It's important to consider the immunisation service offered at your place of work and ensure your workplace improves access to immunisations. So are appointments being offered at times that are flexible and that you don't just have one set clinic? Do you have evening clinics and weekend clinics? Things along those lines. Every effort should be made to vaccinate individuals and no opportunity to vaccinate should be missed. If seeing the individual for a different reason, take the opportunity to check their vaccination status and bring them up to date. Remember, there's no limit to the number of vaccines that can be given at any one time. The only limit is the amount of limbs that we've got to give them. Insufficient appointment time allocated for vaccinations leads to the most common vaccination errors. So the RCN actually recommend best practice is to have a minimum of 20 minutes. However, you may actually need more than this. So think about your first immunisations where a lot of information needs to be conveyed and parents might have a lot of questions, or your 12-month immunisations where you are giving 4 injections, or your preschool immunisations where you have a wriggly toddler who needs convincing. So these might require more than 20 minutes, but 20 minutes is the minimum that you should have for a vaccination. And it's really important to ensure you're up to date with immunisation training, that you've had all your updates, you're reading those vaccine updates, you've had your anaphylaxis and resus training, you make sure you have access to relevant chapters of the Green Book. If you're not a prescriber, ensure you're working from a valid patient-specific directive, or if you are a registered professional who can work off a PGD, it's the most up-to-date PGD and it's been appropriately authorised and signed. But remember to always act professionally and to make sure you have the right skills and knowledge, competence to be able to give an immunisation. Here are some top tips for the prevention of vaccine incidents. Courier to hand vaccines to a designated nurse and not leave them at reception. Check the fridge temperature every time you take a vaccine out of the fridge. Check the Red Book and the computer notes before you draw up and give vaccines. Check the vaccine with the adult in the room prior to administration. And if in doubt, always ask a colleague or check the Green Book. Core Topic 13, the role of the healthcare support worker as an immuniser. Healthcare support workers are a vital part of the workforce and support the delivery of vaccine programmes. They play an important role in administering them, and it is essential healthcare support workers are suitably trained and supported in their role of immunisation. So the Royal College of Nursing supports healthcare support workers to give the influenza vaccine, the pneumococcal vaccine and the shingles vaccine to adults, and the live attenuated influenza vaccine programme for children, and the COVID vaccine in adults also. Only those healthcare support workers with at least 2 years experience and a minimum level of overall education and training in healthcare should be considered for training in vaccines administration. Healthcare support workers administering immunisation may not work under PGDs, and a registered healthcare professional may not delegate any element of care they are providing under a PGD. Healthcare support workers may only administer vaccines under a patient-specific directive or a PSD, and when doing so, the prescriber is responsible for the assessment of the patient and the decision to authorise the supply or administration of the vaccine, and the prescriber must be satisfied that the person to whom the administration is delegated, so the healthcare support worker, has the necessary qualifications, experience and knowledge to provide that care. Core Topic 14, Support for the Healthcare Support Worker. Registered professionals are responsible for delegation of tasks to healthcare support workers, and before delegating immunisations to a healthcare support worker, registered staff should ensure vaccination is within that healthcare support worker's job description, they have been suitably trained and competence has been assessed against recognised standards. Then records on all of this should be kept by the employer. The person who delegates the immunisation must ensure that an appropriate level of supervision is available and that that healthcare support worker has the opportunity for mentorship. Support workers must have ongoing development to make sure their competency is maintained. Healthcare support workers must not be placed in a position where they need to make standalone clinical judgment calls in relation to vaccine administration. To prevent this, there should be clear guidelines and protocols in place at your organisations for healthcare support workers to work from. A healthcare support worker giving immunisation needs to be able to promptly liaise and discuss issues with a registered healthcare professional who is available on site for practical and general administration issues. This can be any registered healthcare professional, but for medicine and prescribing clarification or queries, the registered prescriber needs to be available. Vitamin B12. Both registered professionals and healthcare support workers in general practice are often involved in the administration of B12 injections for the treatment of B12 deficiency. It's really important all healthcare professionals understand the medications that they are involved in giving. Vitamin B12 or B9, commonly called folate deficiency anemias, occur when a lack of vitamin B12 or folate causes the body to produce abnormally large red blood cells. Vitamin B12 is a crucial component of the normal function of the brain, and after being deficient in B12 for around about 5 years, a person will begin to develop symptoms. B12 deficiency causes a wide range of significant symptoms that do worsen over time. Symptoms may include sore tongue, mouth ulcers, anemia, tiredness, breathlessness, feeling faint, headaches, loss of appetite, weight loss, pale skin, hypothyroidism, and even infertility. Symptoms may also include memory loss, and being deficient in B12 for a long period of time may contribute to brain atrophy and dementia associated with B12 deficiency. This is why it's really important that B12 deficiency is picked up early and treated with B12 injections. Because of the significant consequences of B12 deficiency, it's important to be aware of those who are at the greatest risk. So these include people who have a vegan diet, and this is because plant-based foods do not naturally contain B12. And in turn, vegan mothers who are breastfeeding their children are at risk. Also, certain conditions which decrease absorption of B12, things like Crohn's disease, irritable bowel syndrome, gastric banding, and also certain medications, colchicine, metformin, potassium, anti-epileptic drugs, can all decrease B12 absorption. Patients need to be advised to have fortified foods or supplements, such as some plant milks, soy milks and cereals to prevent B12 deficiency when they are following a plant-based only diet. And if people are not on a plant-based only diet, then they need to increase their consumption of fish and meat as well. Initially, when hydroxycobalamin is prescribed, it will be prescribed as loading doses, which are usually done over a 2-week period, 6 doses, so 3 injections a week. So you would normally do it on a Monday, Wednesday and Friday over 2 weeks. This is followed up by a maintenance dose, which would be 1 injection approximately every 12 weeks, but this will vary depending on the person and the prescription. So when administering B12, the core principles of administration, documentation and consent all apply just the same as they do with immunisations, which we have discussed earlier in this course. Now, this is a prescription-only medication, and for a healthcare worker to give it, it needs to have a patient-specific directive in place. If you are not a prescriber, you need that PSD in place before giving. When drawing up injections, because it's a glass ampule, you need to draw it up with a filter tip needle. And IM injections, healthcare support workers are trained to give only in the deltoid muscle, but registered professionals may give it in the buttock or the thigh.